Okay, it's apnea test because it is brain death. Uh, According to the American, okay, brain death is defined as the permanent loss of the brainstem function. Brain death commonly occurs after an acute catastrophic brain injury, secondary to acute catastrophic brain injury, secondary to intracranial trauma, intracranial hemorrhage, or cardiovascular collapse. Brain death may be diagnosed by Brain death may be diagnosed by neurological examination showing absence of cranial nerve reflex, or lack of response to the painful stimuli. An apnea test showing the absence of respiratory drive. Apnea test is most appropriate next step for patients who have already showed absence of brainstem reflex on neurological examination. Ancillary tests such as EEG and angiography can be used. EEG or angiography can be used when diagnosis is uncertain. A patient with brain death is clinically and legally dead. As seen, mechanical ventilation may be withdrawn without family permission, and hospital policies may vary to some extent on the exact timing of the brain death examination, and physician should be familiar with standard care in the individual setting. Okay, do you know how it is done?
No,
Okay, I don't.
like what the apnea test?
Yes, like we are giving carbon dioxide, or we are just stopping the ventilator for a few minutes. I don't
Probably
know.
just stopping the ventilation.
Okay,
Yes.
so according to this, like as GCS is very low and there is no brainstem reflex, so we need to do the apnea test for confirmation that patient is actually brain dead. Then finally we can remove the ventilator without the permission of the family.
Yeah. It
Okay.
says that this is the procedure. They give oxygen, measure blood gas levels, ventilator is disconnected, and the patient is observed for any spontaneous respiratory effort. Yeah, so it's kind of what you were saying. They just disconnect the ventilator and see if she's still breathing. Yeah.
Okay.
Oh, where am I? Yeah. Okay, next. 81 woman comes to the clinic for routine health maintenance. She has felt well but reports painless bruising on her right arm that she noticed 3 days ago after removing a bandage from a healing insect bite. She has noticed similar bruising during the past few years with bandage use and after accidental bumping of her arms against hard surfaces. Hypertension, she has hypertension treated with thiazide. She has no other chronic medical condition, doesn't take medication. Vital signs wells, she appears wells. Physical exam shows 4 centimeters area of ecchymosis with tearing of the skin on the right forearm at the side of the removed bandage. Reminder of the physical exam is fine. Which of the following is the most appropriate next step in management of this patient's skin findings?
Okay. This patient ecchymosis after minor bumps or removal of bandage in 81-year-old patient can be considered a normal finding due to several factors related to his aging process. As people of age, the skin becomes thinner. As people of age, skin becomes thinner and loses elasticity, making it more susceptible to the injury. Additionally, the blood vessel become more fragile and are more likely to break or leak blood into the surrounding tissue, leading to formation of the bruises. In older adults, decreased blood flow to the skin and the underlying tissue, and can also contribute to slow wound healing, making it more likely for bruises to persist. They are these are normal. These are normal physiologic changes expected with aging. It is important to note that certain medical conditions such as clothing disorder or bleeding disorder can increase the risk of bruising in older adults. However, in the absence of many other concerning symptoms or underlying medical condition, ecchymosis, the patient can be considered normal finding in aging process. Further evaluation include thorough medical history, physical examination, and may be necessary to determine if any underlying medical condition or contributing ecchymosis. In this case, without any clear coagulopathy, no implicated medication, and history of examination that are age and situation appropriate, further testing is indicated. No further testing is indicated. No further testing is indicated. For this reason, reassurance is the most appropriate. For okay, for older patient, like ecchymosis is a normal uh, thing for due to aging process, as they have decline in collagen and elastin. So
Mm-hmm.
so we need to do nothing, just reassurance. Okay.
Okay. Next. 58 men comes to the physician because of 1 month history of non-productive cough. He has not had shortness of breath or weight loss. He has type 2 diabetes, hypertension, and COPD. Medication, insulin, metformin, salmeterol, ipratropium, lisinopril. During the exam, the patient coughs frequently. Temperature is fine, pulse is fine, respiration fine, blood pressure high, a bit higher. Pulmonary exam shows prolonged expiratory phase, no wheezes are heard. Reminder of the exam is fine. Which of the following is the cause of this patient cough?
Okay. This patient has non-productive cough for 1 month. Okay. Why it is not COPD?
Why
Because
it is
this
not?
patient this patient has COPD, and this patient is taking like this drug like lisinopril for long. Okay, worsening COPD is reasonable consideration in patient with a history of COPD and increased cough. However, the patient does not report any shortness of breath. Okay, any shortness of breath, no wheezes are heard on pulmonary examination. If the patient has progressively worsening COPD, it would be expected that there would be worsening shortness of breath, dyspnea on exertion. Okay, then it is the adverse effect of the lisinopril, and we know that lisinopril cause the dry cough.
Mhm.
So we don't need the explanation. It's a mechanism type of question. Do you want me to read the explanation?
Nope, it
Okay,
should be fine.
okay.
Yep. 57, woman gravida 4, para 4, comes to the office because of an 8-week history of urinary urgency. During this time, she has had a sudden strong urge to void and is often unable to reach the bathroom in time. She urinates 3 to 4 times nightly. There is no pain with urination. She does not have urine loss when coughing, sneezing, whatever. She has no history of serious illness. Exam shows a mild cystocele and mild rectocele. Q-tip test shows no urethral hypermobility. The cervix, uterus, and anus are fine. Urinalysis, RBCs are a lot. White blood cells, fine, not that many. Epithelial cells, 3 to 5, I don't know. And bacteria, none. Which of the following is the most appropriate next step? So he's peeing and there is blood. He's
Yes.
peeing a lot, there is blood.
Okay. Initially, it looks like incontinence type. Okay,
Like urge.
urge
Mm-hmm.
incontinence, yes. But there is blood. In urge
That is blue.
yes. In urge
Mm-hmm.
incontinence most commonly occurs due to urge detrusor overactivity, urge for detrusor overactivity, and overflow is detrusor underactivity. Okay, it typically presents with urge to urinate followed by the leakage of variable amount of urine. Physical examination and lab studies will show no abnormalities. Post-void urinary bladder residual volume will be normal, and treatment of idiopathic urge incontinence include strengthening the pelvic floor muscle, weight loss, minimizing caffeine and alcoholic beverage intake, bladder training on timed void, antimuscarinic like oxybutynin. When evaluating urinary incontinence, however, it is important to rule out associated UTI, or other pathologies, especially when urinary incontinence is new in this onset. In the past, urinalysis show microscopic hematuria 50 to 100 RBC per high power field, painless microscopic hematuria. mm, Antimuscarinic medication used to treat urge incontinence from an overactive bladder and detrusor instability. Urge incontinence presents with urge to void followed by the leakage of urine. When this patient does have signs of urge incontinence, she also have microscopic hematuria that should be further evaluated with cystoscopy prior to treatment with any medication. Mm. And placement of a mid-urethral sling is used as a treatment for stress urinary incontinence presents with leakage of urine with increased intra-abdominal pressure such as coughing, laughing, sneezing. It is common in multigravid patients because only because of weakness of the pelvic floor muscle and the subsequent loss of proximal support of the urethra. This patient has displacement of vesicourethral junction and hypermobility of the urethra with abdominal pressure. The patient's Q-tip shows no urethral hypermobility, making stress incontinence unlikely. So Q-tip for stress.
Mm-hmm.
Recommendation is to keep avoiding diary can be helpful to monitor the chronic urinary voiding changes and dysfunction. However, it would not be the most appropriate next step in the diagnosis with patients' acute changes in the urine. This patient should be further evaluated with cystoscopy. An ultrasonogram of the pelvis is useful in diagnosing pelvic and ovarian pathologies such as ovarian torsion or ectopic pregnancy, and be it would be helpful and it would be helpful or to be unlikely it would be helpful to be for a patient with incontinence for the diagnosis of bladder malignancy. The most appropriate test for investigation of bladder malignancy is direct visualization and biopsy with cystoscopy. Okay, bladder cancer direct visualization and biopsy with Cystoscopy. Okay.
Oh, by the way, this is nbme 13. It wasn't 12, it's 13.
Yes, it's 13.
24 men being evaluated in the hospital because of the increasing oxygen requirement. He was admitted earlier today because of an isolated comminuted pelvic fracture he sustained when he was pinned between a forklift and a wall while working at a warehouse. On admission, he received 6 units of packed red blood cells, 6 units of fresh frozen plasma, and 5 units of platelets for resuscitation. He underwent external pelvic fixation with right lower extremity fasciotomies for treatment of compartment syndrome. He was extubated at the completion of the operation. Medical history is fine and he takes no routine medication. 6 hours later, temperature is normal, pulse is high, respiration high, blood pressure low. Pulse oximetry on FiO2 of 1 by a non-repeater mask on oxygen saturation is 80%. Physical exam discloses tachypnea, breath sounds are coarse bilaterally. Patient is intubated and mechanically ventilated. Arterial blood gas shows a FiO2 of 1, discloses a PaO2 of 60. Checks X-ray shows bilateral patchy infiltrates. It's too much going on. Which of the following is the most likely cause of this patient respiratory failure?
There is lots of blood transfusion,
Yeah.
and there is like crackles, coarse breath sound show coarse bilaterally. Maybe coarse crackle, and there is bilateral chest X-ray show bilateral patch infiltrate. Looks like trolley transfusion related acute lung injury. Trolley. In transfusion related acute lung injury, it's a rare complication of the blood product. It's a rare complication of the blood product, but a common cause of death related to transfusion. Common cause of death related to transfusion. It is commonly present during or within 6 hours after the transfusion, with symptoms including fever, cyanosis, hypertension, hypoxemia. Auscultation of the lungs may disclose crackles. Chest X-ray will show new bilateral infiltrate unrelated to cardiac dysfunction. The pathology is thought to due to activation of the neutrophil in the pulmonary vasculature by antibodies in the transfused blood, which leads to release of the cytokines and which leads to release of the cytokine and inflammatory mediator. Risk factor for development include patient's risk factors such tobacco use, fluid overload, shock, and alcohol use disorder. Platelet plasma whole blood carry the greatest risk of TRALI. Treatment include discontinuation of the transfusion, oxygen supplementation in the form of non-invasive positive pressure ventilation or intubation, and hemodynamic support. Okay,
Can you
next.
read
Yes. Which
B,
one?
C, and D? B, C, and D?
Okay.
B.
Fat embolism typically occurs after long bone fracture or pelvic fracture due to fat macroglobulin embolization to the pulmonary and systemic circulation. Presentation can include the triad of hypoxemia, petechial rash, and neurological derangement. There is no rash in this patient.
Mhm.
Hypoxemia is present, no rash. Okay, no neurological derangement. Treatment is supportive in involving maintenance of adequate oxygenation and intravascular volume, which of the intravascular volume while the patient is at risk for fat embolism due to his fracture. No rash is present, and development of hypoxemia following massive transfusion is more consistent with TRALI. Pulmonary contusion may occur after blunt or penetrating trauma to the chest. Blunt or penetrating trauma to the chest on chest X-ray. Pulmonary contusion appear interstitial infiltrate and or patchy alveolar opacity often underlying the region of the chest wall. Trauma management of pulmonary contusion is supportive with control pain, pulmonary hygiene, lung expansion, maintenance of adequate ventilation, oxygenation of the patient, while hypoxemia and dyspnea usually develop over 24 to 48 hours. Rapid onset can occur after severe injury. Rapid onset can occur after severe injury to large area of the lung. This can this patient has no history of severe bilateral chest wall trauma, and it's not pulmonary embolism. It presents with pleuritic chest pain, shortness of breath, in the setting of embolization and known DBD. Vital signs may show tachycardia, hypoxia if sufficiently large. Hypotension development is usually 5 to 7 days after the procedure or trauma. A presentation with less than 24 hours is common. It is not associated with it is not associated with coarse breath sound or bilateral patchy infiltrate. Okay.
Okay. Next. 62 men comes to the physician 24 hours after a 20-minute episode of weakness on the right side of the face and right upper lower extremity. Blood pressure is 130/78. Cardiac and neurologic exam, ECG and CT scan of the head is normal. Carotid Doppler ultrasound shows less than 50% stenosis of the proximal left internal carotid artery. Which of the following intervention will result in the greatest reduction of this patient risk for cerebral infarction? Cerebral infarction.
So as the stenosis is only 50%, so we do not need to do the carotid end arterectomy.
Mhm.
In symptomatic patient, maybe 80%, 70 or 80%. If it is 70-80%, then carotid end arterectomy should be done. So, so we need the management like for TIA. TIA is defined as transient episodes of neurologic dysfunction caused by focal brain, spinal cord, or retinal ischemia without the evidence of the infarction. As embolic stroke, it involves an event in which clot breaks off and travels to the brain, occluding the flow at the cerebral artery. Emboli can come from proximal vessel. Emboli can come from proximal vessel internal carotid artery, internal carotid artery, or from arterial thrombus after TIA measures a TIA measures for prevention of ischemic stroke should be enacted. Diagnostic workup includes head imaging, includes cardiac imaging studies, and carotid duplex ultrasonography. Carotid duplex ultrasonography determine the a possible to determine a possible embolic extracranial source of the clot. If no embolic source is identified, an intracranial atherosclerotic related thrombosis is likely cause, and aspirin therapy should be initiated to decrease the risk of future thrombotic event. Aspirin is an antiplatelet agent commonly used in the prophylaxis of arterial thrombotic phenomena involving the cerebral arteries, cerebrovascular accident. Okay.
Can you read E?
Yes, left carotid endarterectomy is used to treat moderate to severe left carotid artery stenosis. Symptomatic refers to TIA or ischemic stroke. Moderate carotid artery stenosis is defined as 50 to 75% blockage. This patient is 50 less than 50% of the blockage. There is a chart as far I
Yeah,
remember.
I remember. There is a chart. I think it was like if it's 50 or more with symptoms, then you do end enterectomy.
Mm,
Or if there are no symptoms, but it's like 80 or more, then you do enterectomy. I don't know. There was something
yes.
like that. I don't remember. Okay. Next. 1 day old male, 1 day. Newborn is evaluated in the hospital nursery before discharge. He was swelling over his skull. He was born at term to a 27-year-old woman gravida 1 para 1 following uncomplicated pregnancy and forceps assisted delivery. Apgar score was 7 and 10. Weight is like 10 pounds. Vital signs are normal. Exam shows 3 times 3 well demarcated area of boggy swelling over the left parietal skull region that does not cross the suture line. The skin over the area appears normal. Which of the following is the most appropriate test to screen for potential complication associated with this patient's skull abnormality?
Okay. Assisted vaginal delivery typically indicated for a prolonged second stage of labor and can be complicated uh, using vacuum using vacuum assisted devices or metal forces. Due to vacuum assisted devices or metal forces, vacuum assisted devices can cause scalp laceration. Vacuum assisted can cause scalp laceration, cephal hematoma, and brachial plexus injury. S- So, vacuum assisted delivery cause scalp laceration, cephal hematoma, and brachial plexus injury due to shoulder dystocia, retinal hemorrhage, and intracranial hemorrhage. Forceps assisted deliveries carry the risk of cephal hematoma, laceration, intracranial hemorrhage, facial nerve injury, skull fracture, or ocular injury. These newborn, whose delivery was assisted with forceps with a large content scalp swelling, most likely develop a cephal hematoma secondary to delivery method. Cephal hematoma occur when when the blood vessels when the blood vessels that supply the periosteum of the skin are torn while accumulate between the periosteum and the skull. It is not typically it is not typically and radially apparent at the birth, but rather develops over the course of hours to days. Cephal hematoma often commonly present as they did not as they did in this patient, a soft area of swelling bordered by cranial suture without the evidence of overlying skin changes. They are managed expectantly while the majority of the resolving on their own. However, they do put the newborn at increased risk of development of jaundice as the breakdown of blood product as the breakdown of the blood product overwhelms the neonatal liver's ability to apparent to conjugate the component. However, this patient's cephal hematoma should have serum bilirubin concentration measured and may be monitored closely for the development of jaundice. Okay, can you differentiate the cephal hematoma and other like scalp problems in the babies?
Uh,
That
not now. Not now, but I feel like we did those questions so
yes,
many. We're
but
doing it.
but that differentiation in the exam is a very hard
It's
nut
very
to
hard.
crack.
Yeah, yeah. I
Okay,
remember we did a lot of them, but every time once I'm done doing those questions, I usually forget it. I don't know why.
so that's the thing. You need to find out what, because these things comes in the question. These type of question will come in any
Yeah,
time. Yes.
they
Okay.
do. They do come. That's true. Because this. Okay. Next. 37 woman comes to the physician for follow-up. She has had hypopituitarism since she underwent surgical excision of a large pituitary tumor followed by radiation therapy 15 years ago. She says that she's generally doing well, but has noticed some increased fatigue, sleepiness, and weight gain during the past 6 months. Medication, levothyroxine, hydrocortisone, and OCPs. Vital signs are normal. Exam shows no abnormality. The most appropriate next step in management is measurement of which of the following.
Okay. This is interesting question. Like every time we do the TSH to monitor the patient, but as this patient okay, measurement of thyroxine concentration is the most important next step in the management, as it provides a direct information as to whether this patient is receiving sufficient hormone replacement to confirm a diagnosis of hypothyroidism. Hypothyroidism is a clinical condition characterized by insufficient production of the thyroid hormone by thyroid gland. Various cause autoimmune disorders, surgery, radiation therapy, and medication-induced hypothyroidism can occur. Deficiency of this hormone, decrease in metabolic rate, manifestation as fatigue, weight gain, cold intolerance, constipation, dry skin, hair loss, and myalgia. Patients that undergo Patients that undergo pituitary surgery are at risk of development of hypopituitarism and thus acquired hypothyroidism. These patients depending on the extent of the surgical intervention will need hormone supplementation for thyroid and adrenal gland function, because TSH and ACTH concentration because TSH and ACTH concentration can be low. Supplementation of levothyroxine or and hydrocortisone is common if these medications are not dosed correctly. Symptoms of hypothyroidism and adrenal insufficiency can occur. In this patient, history of fatigue, sleepiness, weight gain, hypothyroidism should be in concentration, because the patient does not have functional pituitary gland. As a result of surgical or radiation intervention, the typical endocrine pathway hormone secretion is disrupted in here. And look at the TSH.
Mm-hmm. You mean this answer, right?
Yes. Mm, the option. Measurement of free T3 concentration is an appropriate test in the
Oh, I thought you were
sorry,
reading this one.
sorry,
Mm-hmm.
D1. Okay. Measurement of 24 hour radioiodine uptake and serum TSH concentration and serum thyrotropin concentration are appropriate step in the management for patient with hyperthyroidism or hypothyroidism. Measurement of 24-hour radioiodine uptake provide information on thyroid function by measuring the amount of iodine that accumulates in the thyroid gland. This test can be used to evaluate thyroid nodules and assess whether they are hyper or hyperfunctioning. Measurement of TSH and serum TRH, thyroid releasing hormone concentration, test the hormonal pathway of the thyroid hormone secretion to identify the level of the abnormality originates. the thyroid gland, the pituitary gland, or the hypothalamus, because this patient has undergone pituitary intervention and radiation therapy. The physiologic pathway is disrupted, so measurement of this concentration would not offer uh, further information into the case of her symptoms. Okay.
Okay, makes sense. 64 man comes to the office to request help for alcohol use disorder. He says he has tried to stop drinking on his own on a few occasions but has relapsed within several days each time. He has never had delirium tremors or other severe withdrawal symptoms. He has not consumed alcohol during the past 7 days. He reports no substantial symptoms of alcohol withdrawal at this time. He has severe degenerative spine disease for which he is on long term disability leave. He has been taking prescribed hydrocodone and acetaminophen for 11 years. He does not smoke cigarettes. He has been drinking like 12 ounces of beer daily for 9 years. He's divorced and lives alone. Vital signs normal. Exam shows decreased movement in the low back. Oh, Jesus. Secondary to pain. No other abnormalities are noted. Which of the following the most appropriate pharmacotherapy for this patient alcohol use disorder?
So alcohol use disorder accomplished alcohol use user refer addiction to alcohol that must be met at least two of the following criteria: inability to cut back on drinking and drinking more than the expected, excessive time spent drinking alcohol, craving, persistent drinking despite physical and mental related to drinking, and persistent drinking despite negative social consequence. Patients with moderate to severe alcohol use disorder may benefit may benefit from daily medication. Commonly used medication include naltrexone, acamprosate, disulfiram, and gabapentin. Naltrexone is an opioid antagonist. Naltrexone is an opioid antagonist would precipitate opioid withdrawal in this patient taking hydrocodone, an opioid agonist. Therefore, acamprosate, a medication with unclear mechanism of action likely involved in methyl D-aspartate antagonism, is the best option. Why naltrexone? Why not naltrexone? Naltrexone is a long-acting opioid receptor antagonist. It blocks the rewarding effects of the drinking alcohol and thinking about alcohol, thereby preventing alcohol craving. However, this patient is taking hydrocodone, an opioid agonist. Naltrexone would precipitate naltrexone would precipitate opioid withdrawal. Alternatively, the patient would have to taper the hydrocodone and endure opioid withdrawal before giving this. So we are not giving naltrexone. That's why we can give naltrexone, but as he is getting the hydrocodone opioid drug, that's why we are not giving it.
Mhm.
Okay.
Next. 27 men comes to physician because of 8-month history of shortness of breath with exertion. He has a 1 week history of mild shortness of breath after climbing one flight of stairs. He has not had fever, cough, weight loss. He doesn't smoke. He's employed as an office worker. Vital signs are normal. Jugular venous pressure is, I guess that's normal. Don't know. There is clubbing of the fingers bilaterally. Crackles are heard throughout the lungs. Blood gas, arterial blood gas analysis. pH is, where are the labs? pH is alkalotic. Let me double check. Where is it? Yeah, it's normal. PCO2 is normal. PO2 is low. X-ray of the chest is shown. Pulmonary function set FVC ratio is decreased. Diffusion capacity. No, wait. FEV1 FVC ratio and decreased diffusion capacity of lung carbon monoxide. Okay,
That means
never mind.
restrictive lung disease.
Restrictive, yeah. Which of the following is the most likely explanation of the patient dyspnea?
I think the JVP is high too.
JVP is high. Okay.
Okay, this patient presentation and diagnosis with ILD, interstitial lung disease. In ILD, you will find crackle, like in ILD, there may be fine crackle present in both lung. So, consistent with ILD encompasses heterogeneous group of disorder result in pulmonary fibrosis and progressively pulmonary fibrosis. And impaired lung function. Pulmonary fibrosis and impaired lung function causes include various infections, occupational and environmental exposure, drug-induced pulmonary toxicity, and radiation-induced lung injury, connective tissue disorder, hypersensitivity, pneumonitis, and Idiopathic disease. Patients typically present with dyspnea, chronic non-productive cough, inspiratory crackles, and hypertrophic osteoarthritic clubbing may present on physical examination. Pulmonary function tests show normal or increased FEV1 by FVC ratio, decreased lung capacity, decreased LCO. Chest X-ray may show interstitial opacification in the periphery of the lungs through the radiographic pattern, and depends on the specific underlying cause. Okay.
Okay. Next, or you want to
Yes.
read another?
No,
Okay.
no.
62 men comes to the physician because of like 11-pound weight loss during the past 2 months despite no change in appetite. He has mild hypertension treated with thiazide. He's like 5'10" and weighs 195. BMI is fine. Temperature is fine. Pulse is fine. Regular blood pressure is high. No, there are abnormalities on exam. Serum, wait, labs. Sodium is a bit low. Potassium normal. Bicarb normal. Glucose super high. Oh, why is it doing this? Glucose super high. Which of the following is the most likely cause of these lab findings?
Okay. This is insulin resistance. This patient has type 2 diabetes mellitus. Okay, wait 1 sec. This type 2 diabetes mellitus is a metabolic syndrome defined as the progressively increased resistance and predisposition chronic predisposition to hyperglycemia, initially as insulin resistance. Initially, insulin resistance develops. Patients who will compensate with increased insulin production. Over time, insulin resistance will continue to increase and eventually results in decreased insulin production as a result of burnout of pancreatic uh, beta cells in their resultant destruction. Type 2 diabetes mellitus has a strong familial predisposition and is generally associated with obesity, though it can initially associated with weight loss as seen in this patient. Typically, type 2 diabetes mellitus tends to present at above age 40 years old, in contrast with type 1 diabetes mellitus, which predominantly presents in childhood. Treatment for type 2 diabetes mellitus include lifestyle modification, oral anti-diabetic medication, and occasional insulin injection based on the patient response. Given this patient age and subacute progression of hyperglycemia, the most likely cause of this patient's lab is insulin resistance. Okay.
Okay. Next.
Yes.
12-year-old with Crohn's disease is brought to the physician because of a 2-week history of fever. Medication as sulfasalazine prednisone is at the 50 percentile for height and 10 percentile for weight. Vital signs are normal. Exam shows 7 millimeter perianal skin tag. There is mild tenderness to palpation over the abdomen. Labs hematocrit is a bit low. Leukocyte, I guess, normal. Platelet, normal. Serum anti-neutrophil, cytoplasmic and ANCA, negative. Which of the following is the most likely explanation for these lab findings?
S-
Oh, lymphocyte count, I guess, is low.
Yes, lymphocyte count is very low. Normally maybe 4,000 to 11 or 5,000 to 11,000. Okay, so low leukocyte counts, that means neutropenia, and it happens due to the drug like sulfasalazine. Sulfasalazine is most likely cause the fever and leukopenia. Other commonly implicated medication includes cytotoxic TMP SMX, antithyroid drugs, methimazole, antipsychotic, clozapine, and antiarrhythmic drugs. Antiarrhythmic drugs, while patients are often asymptomatic, they may present with fever, severe infection, sepsis, neutrophil normally account for approximately 40 to 60% of the total leukocyte count on a complete blood count. Neutropenia is defined as absolute neutrophil count less than 1500. Agranulocytosis indicates a neutrophil count less than 100. Neutrophil count less than 100 per millimeter cube, while this patient's neutrophil count is unknown. His total leukocyte count is 1000, consistent with neutropenia. The risk of spontaneous infection subsequently increases while when the neutrophil count drops below 500. Treatment involves immediate withdrawal of the complicated medication and treatment of any underlying infection. Additionally, granulocyte colony stimulating factor can sometimes hasten recovery. Okay.
Okay, next. 32 men comes to the office because of a 1 week history of leg swelling and increasing shortness of breath on exertion. Last night he had difficulty breathing while lying flat. 2 weeks ago he had muscle pain, dry cough, and fever, but his symptoms resolved without treatment. Muscle pain, dry cough, and fever. Okay. Today his temperature is fine, pulse is high, respiration normal, blood pressure a bit low, jugular venous pressure is
I told
high.
wrong. It's 5 to 9 normal.
Jesus. Okay. I feel like it changes, or I don't know why. I feel
There,
like it's,
uh,
I
we
don't
have
know.
seen in the first state, like there is central venous pressure (CVP), where JVP and another right atrium, right
Mhm.
atrial is 5 and JVP is 3. That measurement there on that question, I thought that the JVP would be 3 to 5 normal. Okay, in here they said 5 to 9. Okay, we
Oh,
need to look
jeez.
at that question too.
Okay, okay. Diffuse crackers are heard over the lower half of both lungs field. Uh, Grade 2 out of 6 holosystolic murmur is best heard at the apex. There is like S3
S3
gallop.
gallop.
There is 2 plus edema of the lower extremity. Echo shows ventricular dilation and ejection fraction of 20. In addition to diuretic, which of the following is the most appropriate pharmacotherapy? Has leg swelling, shortness of breath, so last blah, so heart failure kind of thing,
Yes,
and fever.
it's heart failure. So
Mm,
in heart failure, we give the drug that prevents the remodeling. And S3 gallop is the classic feature of heart failure.
mhm.
So this patient with dyspnea on exertion, orthopnea, and peripheral edema has echocardiographic findings consistent with acute congestive heart failure. Acute heart failure can be precipitated with numerous causes, including acute coronary syndrome, hypertensive crisis, valvular disease, endocarditis, myocarditis, pericarditis, massive PE, tachyarrhythmia, complete heart block, thyrotoxicosis, anemia, severe vitamin deficiency, thiamine deficiency leading to wet beriberi. These patients likely has viral infection 1 week ago, evidence by his cough, myalgia, fever that is triggered with acute cardiomyopathy. Impaired forward flow of the blood leads to congestion and increased hydrostatic pressure in the pulmonary vascular system. The systemic venous system physical examination finding congestive heart failure can include elevated GVP, peripheral edema, ascites, hepatocellular reflux, pulmonary crackles, and S3 or S4 gallop. Diagnosis is with echocardiography. Treatment involves management of the underlying cause and associated condition, hypertension, hyperlipidemia, diabetes, arrhythmia, as well as appropriate pharmacotherapy. The goals of pharmacotherapy are to improve symptoms and preserve myocardial function, reduce mortality. Medication that reduce mortality in is heart failure is beta blocker like beta antagonists, renin, angiotensin, aldosterone inhibitors, AC inhibitors, ARB, and aldosterone. Of the choice listed, low-dose aspirin, low-dose lisinopril AC inhibitor would be the most appropriate to decrease cardiac remodeling and thus reduce the mortality in this patient. Okay, next.
Can you read E?
Yes. Uh, Sotalol, sorry, prazosin. Prazosin is an alpha adrenergic antagonist multiple uses with mm, with multiple uses including BPH, PTSD, hypertension. The patient does not have hypertension. This patient does not have hypertension, and the administration of the prazosin would make him hypotensive. Okay.
Next. 37 primigravida woman at 15 weeks. Gestation comes to the physician for her first prenatal. She has no history of serious illness, doesn't take medication. Pelvic exam shows uterus consistent in size with 15 weeks. Her maternal serum alpha fetoprotein concentration is 0.2 multiples of the median. I guess high. Well, that's what they mean. This patient fetus is at increased risk of which of the following?
Okay, these patients decreased serum alpha fetoprotein plus.
Oh, it's decreased. Oh, 0.2 multiples of the median. Can, couldn't they just say decrease? They couldn't just say decrease. I mean, oh, jeez.
I know you will talk about this because I do not guess this question because of this problem. Because this percentile multiple, what does it mean? Okay, this patient with decreased alpha fetoprotein concentration plus her mm, her at increased risk for having child with Down syndrome. Decreased alpha fetoprotein concentration plus increased risk of having a child with Down syndrome. Down syndrome is a chromosomal disorder most commonly caused by meiotic non-disjunction, although it can also be caused by unbalanced Robertsonian translocation or a post-fertilization error in mitosis. In it is the most common chromosomal trisomy. It is the most common chromosomal trisomy that results in viable birth. Symptoms and signs include hypotonia, down-regulated palpable fissure, flat faces, simian palmar crease. It is associated with congenital abnormalities, congenital malformations such as AV septal block, dural atresia, congenital megacolon, Hirschsprung disease, and increased risk for ALL and Alzheimer disease. Risk factor includes advanced maternal age, and a risk factor includes advanced maternal age and a previous child with Down syndrome. Diagnosis is typically made prenatally with the routine screening ultrasonography showing increased nuchal translucency and increased beta HCG, and increased beta HCG and inhibin with a decreased serum alpha fetoprotein estriol concentration on the second trimester quadruple screen. Okay,
I think
decrease. Sorry.
the this question was super easy if they had just said that this is decreased
Yes,
alpha fetoprotein. Like, yeah, it's just that I didn't know what the point two multiples. I heard multiples, so I thought it was like increase. You
yes. So
know.
decrease alpha fetoprotein means downs. Decrease fetoprotein, and in
Yeah.
alpha, like in Down syndrome, beta HCG and inhibin is high.
Mm-hmm.
Okay. And
So
in
for
neural tube defect, is there anything like
yeah, neural tube defect right
there
here.
is
The
increase serum alpha fetoprotein?
yeah, alpha protein, gastrochasis and in neural tube defect, the alpha fetoprotein will be increased. It's just that you need to know what that point two multiples of the median mean.
In
Okay.
gastroschisis, also in omphalocele, alpha fetoprotein is increased.
Uh,
Both are same, almost same.
uh, uh-huh. Okay. Wait, in omphalocele is increased too?
Yes. In case of omphalocele, a patient's serum fetoprotein would be increased, not decreased.
Okay. Got it, got it, got it. Okay. Next. 37 man comes to the ED 2 hours after the sudden onset of chest pain while using cocaine. He is on parole for charges of drug possession and breaking and entering. He
And
drinks
another information you need to remember, in
what?
Tay-Sachs disease, it is normal,
Where is it? Oh, Texas disease alpha fetoprotein is
is
normal.
normal. Okay.
Okay. Oh, jeez. I think it just if you we knew that you said the low alpha, if they had just said low alpha fetoprotein, that
So
question
it's
it would have
down.
been like, yeah, it would have make sense. Ugh, whatever. Okay. Um, comes to the ED, 37-year-old man due to 2 hours of sudden onset chest pain while using cocaine. He's on parole for drug possession and breaking and entering. He drinks like 6 kinds of beer per day. Temperature fine, pulse fine, respiration fine, blood pressure is super high. Yeah. Physical exam shows diaphoresis. There are old needle track marks on his arm. He's alert and oriented to person, place, and time. There is no evidence of paranoia hallucination. During the exam, his girlfriend asked him where he got the cocaine, and he provides the dealer's name. An ECG shows an evolving anterior wall MI. After stabilization, which of the following is the most appropriate next step regarding disclosure of his drug use?
Okay. Um, the only situation when physician can legally and ethically break the physician patient confidentially is when a patient is likely to imminently and seriously harm themselves or others. Similarly, if a patient has harmed another person or assaulted a healthcare provider, the physician may opt to report the incidents to the police. Though the patient's cocaine use is harmful to health, it is not likely to cause an imminent or serious harm. In addition, mainstream ethics currently favor autonomy, or that the patient has the right to make choices that are harmful to his health. As such, reporting the patient's cocaine use or the name of the drug dealer would constitute a breach of the physician patient confidentiality. The physician should instead use motivational interviewing technique to elicit uh, change change talk and increase the motivation to decrease the discontinued the cocaine use. Motivational intervention aims to decrease unhealthy behaviors while no while honoring the patient's autonomy okay.
7, girl admitted to the ICU because of 5-hour history of confusion, seizure, vomiting, diarrhea. Mother says the symptom began suddenly with no known cause. The patient has no history of serious illness and no medication. In exam, she's obtunded. There is dry skin, poor skin, trigger, hyperreflection, myoclonus. The mother hovers by the patient bedside and appears to be concerned about caring for her. For a non-medical professional, the mother is unusually knowledgeable about medicine, which she demonstrates frequently, which she demonstrates during frequent conversation with the nursing staff. During the early morning hours on hospital day one, the nurse enters the patient room and finds the mother trying to administer unknown medication to the patient. Further investigation shows that the mother has a history of psych illness and has been giving her own psych medication to her daughter. Administration of which of the following medication is the most likely explanation for this patient presenting symptoms. So, what did the mom give that caused the confusion, seizures, vomiting, diarrhea?
Okay, it's serotonin syndrome. The result of serotonin toxicity can lead to triad acute confusion, autonomic hyperactivity, hyperthermia, tachycardia, hypertension, and neuromuscular excitability, tremor, myoclonus, and hyperreflexia. A consequence of fever and sweating. A consequence of fever. A consequence of fever and sweating. Patient may become dehydrated. Patient may become dehydrated and have dry skin and poor skin turgor. As a result, the serotonin receptor in the gastrointestinal tract, vomiting, diarrhea can occur. Through the serotonin syndrome can occur therapeutic doses medications, especially if multiple serotonergic medications are prescribed. The risk increases with overuse as in this patient whose mother is administering serotonergic medication surreptitiously, meeting the criteria for factitious disorder by proxy. Though serotonergic antidepressant, monoamine oxidase inhibitor (TCA), SSRI are more classically associated with serotonin syndrome, several other classes of medication also increases serotonin signaling mm, and thus increase serotonin syndrome. These medication, mood stabilizer, lithium, and illicit drug, ecstasy, lysergic acid, antiemetics like ondansetron, migraine prophylactics, migraine medication like triptans, and opioid medication like meperidine, dextromethorphan, oxycodone, fentanyl. Management of serotonin syndrome include discontinuation of all serotonergic medication, supportive care of autonomic instability, sedation with benzos, increased fluid repletion, cooling measures. Cyproheptadine is an antidote with non-specific serotonin mm, properties that can be present, but efficacy, but evidence of efficacy is mixed. Okay,
Okay, so lithium can cause
it's
serotonin.
syndrome. Yes, it is not usual.
Usual, yeah, that's what I'm saying. It's not usual. Yeah, okay. 37 men who is a surgeon in the US Army comes to the clinic because of 4-week history of fever, mild cramping, abdominal pain, and occasional bloody diarrhea. During this time, he has had like 7-pound weight loss and decreased appetite. He has not had nausea or vomiting. He has no history of serious illness, no allergies, and takes no medication. 4 weeks ago, returned from a deployment to the Caribbean in support of humanitarian efforts after a natural disaster. During deployment, he frequently ate food and drank water sold by local vendors. He appears uncomfortable but is not in acute distress. Temperature is high, pulse normal, respiration normal, BP normal, abdominal exam shows softness with mild right lower quadrant tenderness. There is no hepatosplenomegaly and no rebound or guarding. Reminder in the exam shows it's fine. Labs hemoglobin is a bit low. Hematocrit believe is a bit low. Add the hemoglobin and hematocrit here. Over here. Male low, hematocrit, male low, yeah. Leukocyte, I believe, is normal. Segmenting neutrophils, I believe, is high. Where is it? Europe, it is high. Bands is normal. Eosinophils is not, it's a bit high. Lymphocytes is low. Monocytes is low. Platelet is normal. Serum liver enzyme activities and results of C comprehensive serum metabolic panel are within ranges. Which of the following stool studies is most likely to confirm the diagnosis?
So it's bloody diarrhea and
Bloody diarrhea.
came from Caribbean. Looks
Wow.
like Entamoeba histolytica. Okay.
Mm.
Infection with Entamoeba histolytica leads to amoebiasis, amoebic dysentery. Entamoeba histolytica is an amoebic parasite that forms a cyst, which can be transmitted through fecal-oral route, typically through the ingestion of the contaminated water. Amoebic cysts may rupture to trapezoid in the large bowel, which may invade the colonic mucosa and interstitium, leading to symptoms of the abdominal pain and bloody diarrhea, or which may enter the bloodstream and can cause hepatic amoebic abscess, which present with fever and right upper body pain. The diagnosis can be made identification of the cysts on ova and parasite examination, which may show which may show trophozoite with endosomes containing red blood cell, as well as by antigen SN or PCR testing. The colonoscopy shows a mucosal ulcer that can often flask shape. Treatment of hepatic amoebiasis include combination therapy with metronidazole and tinidazole, as well as luminal agent like paromomycin or idoquinone. The patient with likely contracted with entamoeba histolytica in the Caribbean when he consumed large food and water. Okay.
Unit B.
Culture of the stool can aid the diagnosis of the bacterial gastroenteritis. Stool culture can help to differentiate. Uh, Stool culture can help to identify the help to, mm, wait. Stool culture can help to identify infection with organisms like Salmonella, Campylobacter, or Shigella. Although Salmonella, Campylobacter, Shigella can present with bloody diarrhea, this patient was recently traveling into the Caribbean where enterohistolytica is endemic, making it most likely causal organism. Okay.
Okay. Next. 32. Oh, you want to take a break?
Yes,
Yeah, I'm tired. Okay.
no
We'll see
problem.
you.